Good afternoon, everyone. I am Metin Gurkin. I am the director of Wake Forest Center for Artificial Intelligence Research, and then welcome to our Artificial Intelligence in Action (AIIA) seminar. And then it's a pleasure to introduce today's speakers, Dr. Masoud Rouhizadeh. And Dr. Rouhizadeh is an assistant professor in the AI in Health Sciences Initiative at the University of Florida College of Pharmacy, and he leads the AI Collaboration Hub at University of Florida's Intelligent Critical Care Center. He previously served on the faculty at Johns Hopkins Medicine, where he co-founded the Center for Clinical Natural Language Processing. With over 16 years of experience in clinical NLP and biomedical informatics, his work focuses on applying large language models to extract social, behavioral, and mental health insights from unstructured healthcare data. His research has been supported by agencies including the CDC, NIH, and FDA. Today, Dr. Rouhizadeh will share how his team is building efficient, scalable AI pipelines to identify social determinants of health from clinical nodes. And then and these are factors critical to outcomes, but often overlooked. His work demonstrates how both small and large language models can support real-world clinical decision-making, even in resource-limited settings. And then I see that some people are online. For those of you who are online, please enter your questions in the chat as the talk progresses, and we will have time for discussion at the end. And then with that, I'm happy to welcome Dr. Rouhizadeh.
All right, thank you very much. Very nice introduction. Really appreciate your time, and thank you for having me this afternoon. Yeah, I'll be, as you mentioned, I'll be talking about leveraging large language models for practical health-scale outcomes and building efficient pipelines for detecting social risk factors. I do not have anything particular to disclose in terms of IP or anything. This is purely research supported by UF, Hopkins, and federal agencies. I want to deep dive into the project of the low resource language, large language models. But before that, because of the collaboration nature of this visit, I wanted to spend maybe roughly 15 or so minutes on the stuff that I'm doing, including the social determinants, but other things that could hopefully ignite some collaboration opportunities, so that broadly speaking, maybe a couple minutes each of the topics I'll be talking. So starting with my background and my journey and an active project. So bear with me for like 15 minutes before I get to the actual research, like description of the work. So for education and training, I have education and training in professional master and human language technology from University of Trento in Italy. PhD and a Master of Science in Computer Science and Engineering from Oregon Health and Science University in Portland, Oregon. And I have 2 years of training in postdoctoral training in biomedical informatics, data science from University of Pennsylvania. This was almost joined with Stony Brook University, but mainly host at Penn. And then after that, after my postdoc, I immediately joined Hopkins Medicine as a natural language processing lead at the CTSI. Over there, they call it ICTR, Institute for Clinical and Translational Research. Same thing, but different name. And we, a couple of months after I joined, we founded the Johns Hopkins Medicine Center for Clinical Natural Language Processing, which we provide a service, research grant, and all that to faculty. And we also got involved into a lot of enterprise level activities for implementing AI and natural language processing. And then I still hold an adjunct assistant professor appointment at the institution, mainly with the BITS or Biomedical Informatics Data Science division. I teach still natural language processing in health sciences for about 8 years now. And then this collaboration, this appointment also helps me to maintain the multi-site social determinants of health project, along with a few other new submissions that we had with the mental health and some other aspects. So I think I have like 3 grants with them under review right now. So this collaboration helps me a lot. And then after Hopkins, right after COVID, I joined University of Florida under the AI in Health Sciences Initiative. It was a major investment, over $75 million from NVIDIA. Chris Malakovsky, he's a co-founder of NVIDIA, he's an alumni of UF, so he donated technically 3 things, this nice building, which we are at. It's called Malachowski, called literally. And then that Hypergator AI, that a huge GPU cluster directly donated and shipped by NVIDIA. And then 100 faculty positions. So that was the package that was offered to the UF. And I was one of them. I was lucky to be one of them. And that helped me secure some funding for creating the medical AI research lab. I had 1 data scientist. I had 2 postdocs. They just finished their term. 2 PhD students, 2 Fulbright master students currently under our lab. I also lead the AI Collab Hub at the Intelligent Critical Care Center. The UF is an interdepartmental, just like CARE. And I'm also a core member of College of Pharmacy's AI task force for incorporating AI into pharmacy research and, more importantly, education to train the next generation of pharmacy students. I have a lot of collaboration with multiple institutions, including a few grants under review, though, with Harvard, Hopkins, and an active grant with Emory. I have affiliation with the UF Health, where we get data from. College of Pharmacy is my home department, College of Medicine, and College of Public Health. But in terms of like giving you a broad umbrella overview of like what exactly I'm doing, I had some core principles, and the basic one is just to enhance healthcare through AI. I know this is too broad, but I really mean it by like, can we translate natural language processing, AI, large language models into real world applications? So that's kind of like my deriving principle. And in terms of methodological sort of course that I'm thinking all the time is, first off, it has to be explainable because it's clinical domain, it's sensitive. You should be transparent, your method should be explainable. You should be able to create through AI computable phenotypes in order to feed into more explainable methods. So that's another major factor that, let's say, from unstructured data, structured data, lab results, anything, you have to be able to create computable phenotype in order to do your next stage of machine learning. And then, speaking of years of experience in multiple institutions and collaborations with multiple institutions, I do know how rare it is to find good computational resources that are HIPAA compliant. So it's not only finding that, obviously a lot of people have that, but to put patient data, that's not so common. And I can talk about this many hours, like the stories, but that motivates me to, like, anything that I built actually should be transferable into low resource settings in order to make it available. And then we think about it as democratization of AI in low resource setting, which is the reality in many other places. And I already talked about fundings and collaborations, multiple federal institutions, multi-site partnership that I always value and try to maintain that relationship. So I'm going to talk about 5 research areas briefly, maybe a couple of minutes each. We might pull up the time. On the social determinants, I deep dive into it, but just to give you a very brief overview, these are very significant factors that very impactful in patients' health, but underutilized, underdocumented, and ignored sometimes in the clinical care system. In a nutshell, what we achieved is we created natural language processing large language models to identify social determinants on a scale up to 20 or sometimes bigger number improvement over standard structured method. We tried to do common data models, incorporate clinical notes, claims, geolocation data, area deprivation index, and all of them could be incorporated into downstream decision support system. It was a grant that is wrapping up with National Institute of Mental Health with Hopkins. And then, as I mentioned multiple times, comparing the efficiency and performance trade-off between modern LLMs versus conventional, easy-to-deploy methodology. Here are some current and under review. So for now, we have a major CDC grant under Emory. There's other aspects, there are firearm safety, for instance, and impact of social determinants, that's one thing. Disparities in diabetes, adverse event, hypoglycemia, that is actually completed. It was with Hopkins. Social determinants relationship and different types of cancer, lung cancer, this one is like in particular on leukemia. And then pediatric leukemia is like a more of a specific population. On research area number 2, I have a interest and focus on Alzheimer's disease and aging. And the challenge here is that ADRD, Alzheimer's disease-related dementia population, face really unique critical risks. It's sparsely documented in EHR. There's cognitive decline that complicates things. So again, this is like a under-documented area which has a lot of potential to use and incorporate AI in. And some of our innovations was we created a ADRD specific pipeline for detecting granular level of suicide behavior, like passive ideation, active ideation, attempts, or the history of attempts, or family history of attempts. So a lot of granularity in that. And then other projects that is also funded by the Florida ADRC is on extracting detailed fall circumstances and fall risks, mechanism, location of the fall, furniture involved, was it dependent or independent fall, like a more fine-grained phenotyping of fall. And then the other project is, which is under review, National Institute of Aging grant, is on frailty. It's not necessarily on ADRD population, but it's on aging. So phenotyping frailty, severity of that, and trajectory. And that this grant actually has a major social determinants components in it, which does that impact frailty-related outcomes. And then these are like a little bit more details of what I just described in terms of projects and fundings. Research area number 3 is on mental health and substance use. And again, the under documentation is just like a common theme. You might be tired of like keep repeating that, but that's the case, unfortunately. And then the other thing is, particular about substance use, is that you cannot have clinical trials on substance use. That's period. It's just like a protected, limited control studies. You cannot do that necessarily. So a lot of times we rely on self-reported outcomes, trying health records with their all with their caveats. But we got like data resources that we have to utilize, including unstructured data, including large language models, NLP system. And we tried opioids, we tried cannabis, and the numbers are, I mean, usually eye-opening, like up to 20-30% more documentation you get from free text compared to structured, simply because it's structured until you get to the diagnosis of that this is like a clinical condition, they're not being recorded. Like substance use is not usually recorded in the structure unless it's diagnosis. But we get a lot of interesting factors like polysubstance use, frequency of use, mode of use, and more interestingly, confirmed non-use, like a patient is not a user of tobacco or alcohol. And it's actually very frequently documented. And this is an ongoing effort. You're expanding into a lot of substances, opioid, cannabis, stimulant, tobacco, alcohol, and all related substances. And then with that, we have another under review on impact of polysubstance and specifically cannabis on adolescent mental health, on suicide ideation, psychosis in particular. Also the bidirectional temporal association. The cannabis use and depression are a chicken and egg kind of problem. Which one started first? That's something that we're trying to get more data from EHR and then sort of combine that and then hopefully at least shed some light on this bidirectional association. And then we're also submitted an ARPA-H grant on adolescent depression screening tool to use existing EHR data as opposed to having them fill out a questionnaire or anything. Can we utilize the existing data without that survey burden? So that's something that we're also considering. And then number 4 is on cognitive impairment. And then cognitive impairment, I actually added this after our discussions. I thought it's mainly on my PhD thesis work, but I thought because of the discussions we had yesterday, I thought it definitely worth mentioning it. So a lot of computational framework that I've done in my PhD work was on autism spectrum disorder, but it uses patient-generated or subject-generated language in order to, it's not physician language, it's patient, like direct patient input, to find cognitive impairment, language impairment, signs in that language, including responding to dialogue, having richness in their lexical items, the sentence length, complexity of the sentence, and all markers that are correlated with early onset of mild cognitive impairment or autism spectrum disorder. And I know that this is a very significant topic that if you're able to find those early signs early on, that would be a huge factor. And I'm trying to see if we can have a screening tool, like a phone screening tool, for mild cognitive impairment to see if you can get that signals from speech, signals from language. But I do not have any active grants yet. We had one rejected like a year or 2 ago, but that would be an area I'd be very interested in terms of collaboration if it's possible. And then area number 5 is on clinical infrastructure in general, like technically not quite bound to a particular disease, is enterprise scale implementation that you have to find HIPAA compliant environment, you have to deal with heterogeneous data and tools. There's integration of SQL-based clinical data warehouses with Python downstream Java. We even had license issue with Java in some environment because they didn't support because of security of Oracle or whatever it is. So there's a lot to deal with in this atmosphere of like getting things implemented at the enterprise scale. But that's an engineering problem which I like. I was busy at Hopkins and less busy at UF, but that's something that I like, to create that end-to-end workflows, to create something that then we can then afterwards use for our research. So this is quite agnostic to the disease or condition or anything, more of a pipeline system development. So we created an OMOP compliant NLP pipeline for COVID, for other social determinants, that has the potential to be incorporated into PCORNet and One Florida. De-identification of clinical notes was also a major factor. And then interestingly, this is not research, but it was a very interesting effort that we could convert EPIC prints of clinical notes from XML, HTML, or RTF, that formats that prints out the clinician see, is very different from what we get. Like we get plain text, but they get like a nice, colorful with all that tabular value. So we reversed engineered that EPIC print function and created RTFs and XMLs, and then converted to a more digestible format. It's called Canonical Document Architecture, CDA. It's in the standard like HL7. So as far as I know, all the Hopkins notes are all converted to that CDA level 1, to be precise. And then we had this effort of like doing a mass concept extraction through ICD, SNOMED, Human Phenotype Ontology, or HPO, and then make those concepts extracted available in Epic Data Warehouse or Slice and Dice or other tools so that clinician could search for that. And then for that, I'll be involved in Open Health Consortium and Odyssey, as kind of like we try to publish standards and tables for OMOP common data models, for instance. And then because of that, it opens up multi-institutional R&D collaboration, including we had a PCORI grant. It was a Hopkins-Harvard collaboration back in 5 years ago for EHR integration for some of the disease that they picked. COVID-19 symptom extraction was a major impact that we created, and we incorporated all those symptoms into a JH Crown repository of COVID. And then for PATH and PCORNet network, we had that effort. We had a project with Kaiser Permanente and Hopkins to share resources and all that. And yeah, so, and then very briefly before I get started into my research in terms of future direction, and after all that, I think a couple of things that I gathered based on the discussions that we had and my own interest is bridging structured and unstructured data with retrieval augmented NLP, which is RAG. I don't know if you've heard of it. Like this is a major research these days for LLM based, but that RAG has a lot of potential. And in my talk, I'll talk about a little bit of it. For clinical trials, including eligibility criteria and phenotypes from clinical narratives, adopt information extraction methods for trial eligibility prediction. Also, I know it's a major observation for equity and diversity and bias in clinical trial recruitment and maintaining subjects. So systematically identify social barriers for clinical trial participation through EHR. That would be interesting application. Longitudinal impact and patterns in social determinants that could change over time, and the structured data most likely would miss. Develop target retention strategies based on the social context. If the requirements of the users and participants could differ from person to person, so that would be something to find at-risk population. Other thing is capturing mental health and substance use that could potentially impact the trial outcomes. potential confounders and treatment barriers, and then improving trial outcomes throughout more data integration from EHR. So after the trial results are there, the participants could have EHR that could be combined with the trial result. So all of these are like potential that I could imagine that AI NLP could help. And then in addition, I'll be always open to collaboration with other institutions, and data analytics could definitely be impacted. We had discussions about multimodal expansion to speech, to EEG signals. That would be one area to explore. The other is advanced aging and ADRD research. I know it's a major initiative and major research topic here, so that would be something that definitely we can continue. I personally like mental health and substance use analytics. I think it's a major thing that has to be studied further. And clinical AI infrastructure, scalable methodology, common data models. And then last but not least, we always deal with interdisciplinary teams. So it's always necessary to speak the same language or similar language and communicate. So that's one thing that I always prioritize. Okay, I think I have roughly 20 minutes or so, so I have to be quick. And just as a disclaimer, this is under review work. It's not published yet, so hopefully it's to the standard that you like, but I'll be open to feedback, and because it's an ongoing work, I'll be very interested about your comments. All right, so social determinants of health I briefly talked. These are very important factors, including education, access to health quality, neighborhood characteristics, social community context, and economic stability. There's huge attention to it from various places. And I don't know if this looks familiar to you, but this is a map of Forsyth County. I don't know which I just always get confused, but on the left side, you see the life expectancy, and these are a little bit small fonts, but it spans roughly 10-15 years of differences within like a county limits. On the right side, you see area deprivation index, which is a composite score of income, education, employment, and housing. And it's always like shocking to see this, and this is true for Gainesville, this is true for Baltimore, this is true for here. And you see that, like, depending on like what census tract or zip code you live in, there's significant life expectancy differences.
It's a highway, actually. Is it I-50 or something?
I think it should be, yeah.
We looked into that before. For many of the similar maps, there's a highway dividing. Just,
interesting.
Yes.
Yeah, that's the boundary. Like
boundary.
Yeah, like a river.
Right.
Interesting.
Right.
Yeah. So, I mean, it's always. I mean, I should get used to it, but always shocks me to like see how much this could differ from community to community. The issue with area deprivation is that this is great, this is accessible, but this is a community level. It's not individual patient level. So you can use it, but it's a proxy, not exact, precise, personal, individual level information. And again, just a little bit more background on social determinants. This is from National Academy of Medicine, published research. That 80% of what impacts a person's health is non-clinical factor, including socioeconomic factor like education, employment, income, family, community safety, behavior like smoking, tobacco, diet, exercise, alcohol use, sexual activity, and environment, air and water quality, housing, transportation. These numbers, obviously, depending on the funding and location, they could change, but we get the ballpark of how important they are in person's health. And unfortunately, most of these are under-documented in electronic health records or health systems. And that's why CMS, Center for Medicare, mandating for starting 2025, starting from inpatient, the institutions to document 5 domains, including housing, food, interpersonal safety, utility bill payment, and transportation. And then that had impact on the hospital ranking if they report that. So US News uses that, and a lot of places actually use that. There was an initiative in North Carolina. I think one of the publications I have here was like specifically about North Carolina.
Our hospital asks for those. So I have a doctor appointment next week.
Yes.
They ask all of those questions.
They do.
To me.
Yes. My son had an appointment like 2 weeks ago. Yeah, I had to fill the entire thing. Yeah. Now they're mandating, like CMS mandates that. But the issue is that this is looking forward. We have like years and decades of records without any documentation. So if any retrospective analysis that we want to do for any of these that we talked about, it's also an issue. And then the other thing is the completion rate is not as great in the structure. So there's a lot of opportunities here, and this is just a ballpark, but there is a tip of the iceberg is on the structure side. A lot of things are going on the free text, and including social determinants. And so that's why here is the opportunity for us to dive in as an AI researchers. And then we have actually shown that it's not only a claim, we have shown that we get up to 5 to 35% increase in terms of documentation compared to structure with very simple regular expression keyword search approach that we did like at Hopkins a couple of years ago. You get a lot compared to just relying on structure. So you notice the 5 to 35 times increase in terms of the percentage of the coverage. And I think there was a question of like how prevalent they are documented. So I think the numbers are fairly accurate, roughly between 3 to 5%, sometimes with substance use up to 20-30% they're documented, and a lot of substance use are actually negated document, like this person is not a substance user. So, but 3.56 was the cannabis that we found. They're users of cannabis, for instance. So it's different, but we get a huge gain if you use NLP compared to structure. All right, I think it was sufficient for me to just explain like how important the topic is and how opportunities are. But okay, what are the challenges? We got lost in translation, or in this case, lost in documentation. I have like millions and millions of notes to deal with. But because there's not a lot of standardization for social determinants, we have the flexibility and liberty of documentation here. So we can have the same concept explained in a different language, like patient is homeless, stays in shelter, has trouble finding a place to sleep, and so on and so forth. There's a lot to sort of look for. It's like a semantic, meaningful problem. And then best of luck with the regular expression methods. We developed, like this is literally one of the regular expression I developed. This is in Python. I had translated it to SQL. And I have, I think, 50 patterns like that. It takes days and nights, very good eyes, and always there's prone to errors and all that. Very hard to maintain, to do rule-based regular expression methodology to find that. So we have done that. I'm not going to do that again, honestly. It's not efficient. And then we have data mountain. First of all, I mean, the numbers that I'm presenting here is nothing compared to what we heard about Wake Forest and then Midwest and all that. But I mean, at least they're significant in the scale. So I know you have like 7 million, and then what was it, like 17 more million people in other places. But you get it. Like after you scale it up, like you have millions and millions of notes to deal with across institutions. And then the other issue is like 99.5% roughly contain no SDOH information. So your problem, machine learning problem, is easy. If you say nobody has any SDOH problem, you're 99.5% accurate without any compromise. But this is not what we're looking for. We're looking for finding through that your population. And then again, for I think the fifth time, saying that we have HIPAA compliance issue, high trust issue, servers that could help us build this. So here's the objective. Based on this background, can we develop an advanced pipeline that can, one, computationally efficient and scalable? And this is important. Two, minimizes manual labeling requirements. So not all of us have access to chart reviewer. And then at the same time, out of that 0.5%, can it effectively capture social determinants of health complexities? So these are the three challenges that we hope that LLMs could help us with. And here's the framework, and I'm going to go back to this later, but this is the framework that I show it for SDOH, but that could also be applied to other domains. Just look at it in your own research lens in case you're interested. But I think this is something that we're sort of proud of it. And as I mentioned, it's under review in a couple of journals, but I'll be very open to feedback and flexibility for other things. So we call it retrieval augmented classification. And this is not the name that we came up with. This is a common technique. But we translated it to this domain. So a couple of issues. So we have this 0.5% social determinants information, 99.5 irrelevant. And then one objective is, can we limit our search space and human annotation and also machine learning classification? Can we limit that search space to the top 5%, top 10% in order to reduce the computational and human effort in the order of the magnitude? So that would be one objective, to just focus on the top K, hopefully top 5%. That's the goal that we're looking for. So that's objective, a very important objective to consider. And as I mentioned, keyword and search methods, they're good, but they're just a prototype baselining. Over 50% of relevant information is missed because there's obviously a lot of ways to talk about it, so low sensitivity. And at the same time, you get a lot of false positives, like if you look for the word place, there's a lot of orthopedic references to the word place, and we have to deal with that. We have to deal with a lot of that. So low specificity. I don't really recommend keyword and phrase search in social determinants. Named entity recognition, you're looking for sequences of words and phrases. Now you get better leverage compared to keyword. This is good. You get like a lot more better precision or specificity. But again, because of the variations of those phrases, you get low sensitivity. So we tried all of that. We tried NER, we tried keyword search, regular expression. So we have to do better. We have to do better. And then here's the pipeline that we're suggesting. And I'm going to walk you through, hopefully in the next 5 minutes, I'll zoom in other places. So it has a couple of components. To start with raw clinical notes from Epic Data Warehouse. We do some text processing, text segmentation, sentence segmentation, and then convert things into vectors through LLM vectors, put them in a vector indexing database in the middle. On the other side, on the right side, on the step one, we created social determinants patterns and queries through experts. We put them again in the same vector, same LLM as we did the nodes. And then that vector indexing does the search for us, Quadrant DB. I'll go into detail a little bit. And then we retrieve the relevant ones based on the similarity weights of the two. And then once retrieved, we get that feed into classifiers, LLM and transformer classifiers for SDOH classification. And the efficiency comes in the stage number 4 and 5 to find good classifiers that are accurate enough, but also efficient enough. So that's the research question to find in number 4 and 5. So very quickly, on data sources, we started with 500 patient charts, and it's a lot to go through, and we manually annotated that, and like thousands of sentences, only 100 patients. We decided 30 days before and after the SDOH diagnosis, it was like almost like 13,000 sentences to go through. So it's a huge cohort that we sentence by sentence annotated to create that solid gold standard that any claim that we talk has to be supported by real world. So we spend a lot of time on the annotation. So 100 patients with housing instability, 100 random patient, that was our initial, but we focused a lot on 120 notes for controls and for SDOH patient. And integrated reliability was over 97%. So that's our gold standard cohorts, 13,000 number of sentences. And from now on, I'm going to focus on that. All right, and then we did a lot of text segmentation and extraction. And you might wonder why you bother that. And interestingly, because all these LLMs are very sensitive to the sentence boundary, the way that you chunk your sentences actually matters a lot. Like if it's too long, it gets lost. If it's too short, you don't get a lot of context. So we spend actually a lot of time, because of the cascade downstream issues that we observed, we spend a lot of time on building a reliable sentence segmentation framework. And this is not like a research that we can necessarily publish, but in practical, this is actually a crucial step. And then it ended up having a difference of like 5 or 10% down the road. So I would not underestimate the pre-processing before you feed things into your model. So that was one thing, one observation. At the end, we ended up picking a Stanford tool called Stanza. It was trained on mimic clinical text corpus. I highly recommend it. All right, and then for models, there's a lot of models out there that you can, after you created your sentences, you could create your semantic vectors. We have a lot of options, but by far the best one was, the most favorite one was MPNet from Microsoft version 2. So I highlighted, I present the results with the runner-up of the mini LM. We tried many other biomedical models, partially because social determinants are not necessarily clinical, they're like social behavioral factors. The general purpose models work really, really well here. So we created that vectors through Quadrant Vector Database, and we saved that. And then we created queries. That was a story to create queries to find the sweet spot of like how many queries. You don't want to be too concise, but you don't want to be too overwhelming. So we tried different tiers of query, like 10, 25, 50, 100, and 20. We use medical experts, we use coding system, taxonomies, and all that. All right, and then we want to minimize. We want to get, we can get top 20%, top 10%, but can we get to the top 5%? How accurate we can go? So the goal is to minimize as much as possible. So we found the top 5%, and I'm going to show the numbers. So in terms of the models, on the top 5%, here's the performance. It's called recall at top n%. So recall means how many of the SDOH you have captured without missing. And MPNet, with all that queries and all that, with the best query combination, best top K combination, MPNet was fabulous. So it's like 99.3% recall. Pretty much all the things that we were looking for, we found through MPNet and others. We found that. And then after that, mini-LM was very good. So we stick with MPNet for the rest of the project because of its robustness. And then here's the impact of the queries, like enhanced versions, standard versions, all that. We found that the 50s are a golden number here. So we get up to like, again, 99% through 50 phrases. And then in terms of the threshold funding, given the 50 phrases, given MPNet, the top 5% was the most efficient one. Obviously, if you go to lower you get like a perfect recall. You obviously don't miss anything. But in terms of the scale and the coverage, we like the top 5% because of the efficiency. You don't get a lot of too much input. So that's another key finding. And then again, despite filtering 95%, you still have 0.5% of that 5%. So you still have 90% irrelevant information, even in your top 5%. So I hope that makes sense. And then for that, we want to create a classifier that not only performs well, but also efficient enough. So we limited our search space, but the efficiency is still there. So we have to do that efficiency pipeline. We tried a variety of models, like BERT family models, 5, 4, this is just state-of-the-art new models, Mistral 3, Google Gemma. And our goal was just, can we do this? We did all the benchmarking on a consumer-grade NVIDIA desktop, like a gaming desktop actually. It's a RTX 4090 GPU. It's just a couple $1,000 GPU. Except for the fine-tuning of the models, we cannot do it on this GPU, but any fine-tuned model, you could put it on the consumer grade. So the inference time is the major thing, not the fine-tuning time. So all the inference benchmark will be on this desktop, except for the fine-tuning, which we couldn't do it technically. We used 2,000 samples for testing, and then depending on the model, some of them required a lot more training, some of them actually zero training. So I'll go to that as a table, and then two matrix, performance, and then efficiency, like how fast is the model in terms of the number of minutes. Very simple, like how many minutes does it take? And then approach one was just fine-tune the BERT family model. There's our robust established transformers that we try to fine-tune them. They're very good models. So we definitely have them in the benchmark. Details are there. I just don't want to bother you with the number of epochs and all that, but I'll be happy to share. And then the other thing was just a few shot. In few shot, you just provide 15 plus number of carefully selected examples in your prompt that this is a housing, this is a not housing issue. So, and then you try to get edge cases and all that, but only 15 examples. And then the good thing about Fuchsia is there's no training time. You just get the model straight out of the, download it, and then you run it. And then fine tuning, you get more, like we used a few thousand examples for positive and negative. And then we use Microsoft 5.4, Google Gemma 2, the smallest version, which is a 2 billion parameter, and then Mistral 3. Again, the details, I'm just going to save it for the paper and discussions. So here's what we found. I'm going to spend maybe 2 minutes. I'm sorry, I'm just a little bit over time. But so the first of all, the clinical BERT full fine tuning, it was very fast. It took a few minutes to do the training, and then about 1 minute to do the inference. What's the downside here? It requires 8,000 annotations in order to get to the performance that is reasonably well, like 90% FS score for clinical BERT. Then Phi, 3, Mistral, and Gemma 2, they're very good in fine-tuning, out-of-the-box fine-tuning. It takes a few minutes for each of them to do the annotation. For 5 to 7.5 minutes. Mistral was a little bit longer, but the winner here is Gemma. It's not too far off, like it's 85% FS score in terms of precision and recall that you get, like in about 3 minutes. We get very reasonable performance. And then we did the fine tuning, which is a lot of time. It took like for Phi, took a few hours, like 7 hours for Phi, 4 hours for Mistral, but only around 20 minutes for Gemma 2. And obviously these are gold standard, like that 95%, 97% is really, really high, but that requires a lot of GPU time to fine tune. The winner again here is Gemma 2 because it gets you close to that, with a fraction of time, in like 20 minutes in our sample. So the rest of it is just talking about that. But as I mentioned, this is applied to various other pipelines, including substance use, suicidal behavior, and all that. And then the takeaway here is you don't necessarily need the fanciest LLMs. With smarter fine-tuning, smarter lower scale, you can deploy your model. Sorry, I just spent 5 minutes over time.
No, this is good. This is good. This is great. Yes. And this is all.
Right.
Thank you.
Thank you.
This is exciting. I have several questions, but I'm sure the audience has some questions too. Do we have any questions on the chat? Okay. Any questions from the audience here?
I have one question.
Yes.
About the like running NLP or LLM on the, let's say, text notes available and let's say one Florida, generating variables. So I think also said that those variables can help other researchers to use these variables in their machine learning models. One question I always have is how generalizable they are. So when we develop AI model, let's say all-cause mortality, when we develop a model in the Wake Forest data, we want this model to be also performing well in Montana, in Arizona. If the input of this model is coming from this kind of methods, let's LLM, NLP generated, how generalizable? Because it means that we are going to use similar model in Arizona and others to generate these variables.
Yeah, well, technically you're not allowed from a HIPAA perspective because the models, the argument against it is that because someone can reverse engineer the models, they could reverse engineer PHI from it. Even if you de-identify, it's not sufficient de-identification because you cannot, if you get 99% note de-identification, in 100,000 notes, you get 1% and that's 1,000 notes worth of PHI. HIPAA doesn't like it at all. IRB doesn't like it. So, short answer, you cannot ship your model that you trained on Florida or Hopkins or whoever and then give it to the other. So that's the downside. However, one avenue that we're investigating is synthetic data. Like, okay, now I cannot send that, but can I send can I create, and we have that on social determinists, we're working on it. Can I create like 10,000 examples? And it's like in 1 week of prompting Cloud or GPT to get that to you, and or other constructs of interest. And then train it, fine tune it, and then obviously you can ship that model. And the question of generalizability is no longer like data trained on Florida to be generalized. It's data trained on synthetic. And then that gives you a little bit more flexibility in terms of different, let's say radiology formats from place to place could be different. As long as you create that framework of good prompts for synthetic data generation, I think that generalizability would be flexible to the new institution based on their format. So I hope I answered your question. The basic thing is just you cannot ship your model.
Okay. So mostly just one addition, so I don't want to take a lot of time. Like from the HIPAA, that's a great point. But how sensitive those models are to local demographics characteristics? Like when you don't train this model in Wake Forest, let's say, it's learning more from how physicians take notes here, what is this? So
they are.
If you created Florida synthetic versus North Carolina synthetic, how similar those synthetic?
Will they generate the exact same data in different cohorts?
I have this. This is on Kaiser Permanente, and this is not synthetic notes, it's synthetic patterns that we tested at Hopkins. So let me show you. Kaiser North California actually got better results than we got at Hopkins. Same system. They didn't share data. We shared the synthetic driven models. Kaiser Mid-Atlantic got much worse because what was it? It was a shelter through the training, we got the shelter. And then Mid-Atlantic got a lot of questions and discussion about dog shelter in there. Like millions of notes, they got skewed towards that. And then we figured it out. I mean, that was like a one simple explanation to, yeah, obviously it changes from place to place. Yeah, I mean, I wish I had a better answer.
No, that's
yeah.
wonderful.
Yeah.
Thank
Yeah.
you.
Dog shelters versus unhoused shelters.
Yes.
Politically correctly saying. So I have a question. Just you said that there are strategies for clinical trial retention. Can you tell us a little bit about that? That sounds very interesting. The use of NLP for clinical trial retention, which is a difficult challenge, right?
Yeah, I mean, so I'm seeing a couple of potential. One would be obviously finding the at-risk population through NLP. So that would be an obvious. So if your participants are from a certain social risk factors, then most likely there's a dropout and all that. So you have to be more proactive, triaging like all those participants through your social needs risk scores, and then doing more follow-ups. That's one avenue that I feel like strongly that it could help. The other is, I was thinking also a messaging system. That could be actually either automated or semi-automated. So you could use the power of generative models to sort of have this follow-up chats, follow-up conversation, either, I don't know, through phone, through some modalities that they're comfortable with, or maybe through their Epic messaging system, which, by the way, will limit people who have a smartphone and all that. But text messaging is one thing also that could potentially, they have more access to.
One of our faculty actually has a grant on sending messages proactively to patients. Yes.
Perfect.
Yes.
Then, I mean, welcome to the LLM world. They're very good at this, keeping the conversation. Yeah. So if you have an infrastructure to do better prompting, finding those social needs, and then make it more personalized based on their profiles, then that would be another strategy to do the retention and then follow up. So those are immediate thoughts, but definitely worth a lot more conversation.
Like that. That's great. Thank you. Any other questions? So you mentioned a couple of times that with the use of NLP approaches when it comes to SDOH, you are observing 20 times more improvement, and then when it comes to substance use detection, 25 times improvement.
Yeah.
When you do these measurements, can you just walk us through just how you compare, just how you get these 20%, 25%? What are you comparing? Just the details. Just compared to what? Where does the ground truth come from? Because just it can be a little bit tricky, right?
Yeah, no, exactly. That's a great point. So the ground truth, so to speak, the structured representation comes from simply ICD codes. Like, we don't do anything fancier than structured, except for ICD codes, because these are the sort of the mainstream structure. We have tried questionnaires, but we call them semi-structured because there's a lot of text input sometimes, there's like degrees and all that. So we didn't use the questionnaire we didn't refer to questionnaires as a structure. So that does not include questionnaires and surveys. So we only deal with ICD codes, and this is a category of Z codes for social determinants, and I can tell you Z59.1 is housing instability, Z25.0 is homelessness and all that. And there's 9 more here and there, food insecurity, and I almost memorized them because I use them pretty much all the time. And so that's kind of like, that gives us the structure, and then from the unstructured, this is what we get from NLP. But NLP, what I didn't talk about is this is the note level that we create. This, what we get is from sentences and notes. But that's not the whole picture. What's the patient level? And actually, that's not even the whole picture. We're missing something in between. It's called encounter level.
Yeah.
So it could change from time to time. Obviously, changes from patient to patient, but changes from like 6 months later, it could change. So, long story short, to answer your question, we get the homelessness ICD code. We get 6 months before, 6 months after, process all the notes, find instances of homelessness, and that would gives us that patient profile. And then we do this 1 year window on a lot of other patients to find instances of housing instability, like within like a sliding 1 year window. And then now we compare the prevalence rate of documentation between the.
Wow.
Yeah.
That's really good. And
Sorry.
no, this is fascinating. And with the new CMS requirement, actually, you will be able to get much more concrete data.
Yeah,
As you
yeah.
said, just, you will not be able to
Yeah.
get back, but it can really give you a nice comparison tool.
Yeah.
And NLP has always been important, but with the introduction of large language models, just that importance and then also the impact is going to be multiplied.
Exactly.
And then your talk actually really demonstrated to us how to efficiently and effectively use the large language models within the context of NLP, because a lot of people said, well, now that we have LLMs, why do we need an NLP? Just, you are demonstrating how important it could still be, especially within the context of social determinants of health. And I want to thank you for this exciting presentation. Thank you.